if you see this instrument, you are able to see there is a lock and the blades are having only single tooth. Okay. So, this means this instrument is going to be a tenaculum, right. So, this is your tenaculum. Okay. So, how it is different from the valsalum, you have to know. Remember, this is a straight instrument and single tooth is present. Clear? So, this instrument can also be used to hold either your anterior or posterior lip of cervix in various procedures. Clear? Right. Now, coming to this one. So, this instrument, if you see, it has got a handle. Okay, you see there are so many graduations. It is an angulated instrument and you have a tip. So, this instrument is your uterine sound. Okay, so this instrument is your uterine sound. Usually, this is 30 centimeter long angulated instrument. You have got granulations. Okay, and this is angulated approximately 7 centimeter from the tip, which is the normal uterocervical length. Okay, so we can use this instrument to confirm the direction of uterus. Okay, that is, we can check whether the uterus is anteverted or retroverted, and it also measures the uterocervical length for various procedures, right? Yes. Now, we have one more instrument which is somewhat similar to your uterine sound, that is nothing but your bladder sound. Okay, how to differentiate it from your uterine sound is very important. Okay, so we'll see that points alone. So, it is comparatively shorter in length than your uterine sound. Yes, and we don't have any graduations here. See, it is just a plain tip only, right? So, there is no graduations and the tip is also more blunt. Okay, so tip is going to be more blunt, and if you see the angle is very shorter from the tip, whereas I told you here it will be approximately 7 centimeters from the tip. Okay, so these are the differentiating features between your uterine sound and your bladder sound, right? So, this instrument is going to be a Pinard's stethoscope, but we are not using it nowadays. It is being replaced by your uterine Doppler as well as your stethoscope to hear your fetal heart sound, right? Yes. Coming to the next instrument. So, this is your manual vacuum aspirator syringe. Okay, if you see the parts, you will have a plunger handle. Okay, the important characteristic feature is this knob, okay, or valve button. Okay, this is valve button. You have a cap and you have a barrel with marking. Okay, so this is your MVA syringe, that is manual vacuum aspiration syringe. Now, what are the indications of using this instrument? It can be used for MTP up to 12 weeks, right? Then it can be used in incomplete abortion or missed abortion as well. Then to evacuate blighted ovum or hydatidform mole up to 12 week size. It can be used for endometrial biopsy or aspiration also, right? Coming to the next one. So, this instrument is going to be your menstrual regulation syringe. Okay. So, this is not anymore used now. Previously, it was used to terminate pregnancies that was less than 7 weeks. Okay. Now, this instrument you are able to see like this. Okay. There are serrations and you have a lock. Okay. So, this is going to be a sponge holder forceps. Okay. This is going to be a sponge holding forceps. Sponge holding forceps is basically used during antiseptic dressing of abdominal operations like cesarean section or hysterectomy, then to grasp lip of cervix in case of DNC, or when you need to repair cervical tear after delivery like that. Okay. We can also use it to remove the placental membranes or the placenta itself. Okay, placenta and membranes after normal delivery or cesarean section, right? Yes. Now coming to the next one. So what is this instrument? This instrument, you don't have serrations. Okay, if you have serrations, then it is going to be a vaginal word retractor. Here you don't have any serrations, so this is going to be a curette. Okay, so basically you have a blunt end and sharp end here. Okay, the blunt end will be used in dilatation and evacuation operation, whereas the sharp end is used to curette endometrial cavity in case of any gynecological conditions. Okay. Yes. Now coming to this instrument. This instrument is your forceps. Okay. Yes. So this is basically an outlet forceps because it is short and stout, right? So let us see the parts of the forceps first. So you have a pelvic curve here. This is your pelvic curve, and what is present inside is your cephalic curve. Okay, so these are the shanks and you have a handle. Okay, so these are called as your blades. Clear? Now what are the indications of your forceps delivery? So for the fetus, when there is fetal compromise is expected, okay, like there is a meconium stained liquor or there is an abnormal CTG or cord prolapse like that, okay. And for the mother, when there is a prolonged second stage, okay, when there is a prolonged second stage, or in some cases when you want to cut short the second stage, okay. So cut short second stage conditions like eclampsia, severe preeclampsia or a heart disease, any spinal cord injury like that, and even in case of maternal exhaustion. Okay. So I told you this forceps is going to be outlet forceps. So what are the indications of using outlet forceps? When you can use an outlet forceps? Okay, what are the prerequisites? So that will include, first one, fetal scalp should be visible, okay, without separating the labia. Then fetal skull should reach the pelvic floor, and then fetal head should be on the perineum, and importantly sagittal suture should be in the anteroposterior diameter, okay. Then the rotation needed should not exceed more than 45 degrees. Okay, so these are the prerequisites for applying an outlet forceps, right? Now, so you cannot apply forceps, that is forceps is contraindicated when you have a floating head or there is an incompletely dilated cervix, or you have an obstructed labor, or in mall presentations, be it face presentation or bro presentation. In mall presentations also you cannot apply forceps. Clear? Now the direction of pull of forceps will be straight horizontal, and then it will be upwards and forwards. Okay, so this is how the pull will be. So the direction of pull is going to be straight horizontal first, then upwards and forwards. Clear? Now what is this instrument? This instrument is your ventouse, right? So ventouse is basically used when there is a delay in first stage of labor. So a ventouse is basically used when there is a delay in late first stage of labor, which is not corrected by oxytocin Then in case of incomplete rotation, for example, your occipito-posterior position or occipito-transverse position like that. So, this is used as an alternative to rotational forceps delivery. Okay. And you can also use a trial of Ventouse instead of a trial of forceps. And finally, it is used in second baby in twin presentation, especially when it turns out to be a vertex presentation, when there is a delay or when the head is higher, right? Yes. Now, this is where you will apply the Ventouse. Okay. So, normally you have a flexion point, something called as flexural point, that is situated on the sagittal suture. Okay. That is moved close to the posterior fontanelle as well, and it will be 6 cm away from the anterior fontanelle. Okay. So, this is where you have to keep your Ventouse. Okay. Now, what are the contraindications of using Ventouse? Ventouse is contraindicated in face presentation and after coming head of breech, but for after coming head of breech we will use forceps, that is Piper's forceps, but Ventouse you shouldn't use, right? And whenever you have suspect any fetal coagulation disorder. Okay. It is not always an alternative to forceps delivery, that's right. Okay, so we can use in certain conditions, but it is not always a replacement to forceps delivery, right? Now, what happens with Ventouse is when you use, the pressure will be gradually raised at the rate of 0.1 kg per centimeter square per minute till you will attain 0.8 kg per centimeter square. Okay, so approximately 608 millimeter of mercury of pressure will be attained. Okay, so the time that is taken to reach this effective pressure will be usually around 6 to 8 minutes. Okay, so that is important. Now, when you apply Ventouse, you will be able to see something like this in the baby. Okay, baby's head. So, this is nothing but your chignon. Okay, so chignon is nothing but a artificial caput succeedinum. Okay, artificial caput succeedinum that is seen during Ventouse applications, and it will usually disappear within 12 to 48 hours. Clear? Now, these are your various retractors that are used during your cesarean section as well as hysterectomy surgeries. Okay, so first one is your L-shaped retractor, which is your Lagenbach retractor. Then you have your Devers retractor, which is somewhat S-shaped. Okay, so this is your Devers retractor. This is going to be a Doyen's retractor. Okay, you are able to see this concavity, and when it is straight like this, okay, somewhat like this, then it is going to be a Morrison retractor, right? You are able to see the handle difference also here, right? Okay. Now, so this is a self-retaining retractor. The advantage of self-retaining retractor is you will need less assistance, okay, and you don't need to use of so many retractors there that will be hindering the surgical field, okay. So, what is this instrument? This instrument is your episiotomy scissors, right. So, you have so many maternal benefits of giving episiotomy, like it will prevent laceration or any complete perineal tear or even hematoma. Okay, but recently we are not giving routine episiotomy for all the deliveries because WHO doesn't recommend it. WHO recommends only 10% rate of episiotomy for normal deliveries, right? Now, let us see what are the structures cut when you are giving an episiotomy. First one will be your vaginal mucosa, and then it is going to be your superficial and deep transverse perineal muscles. Then it is your bulbospongiosus. Also, some fibers of levator ani are also cut. Then you will be cutting some of the blood vessels and anterior branches of the internal pudendal, artery as well as nerves. Okay. Then finally it is going to be your subcutaneous tissue and your perineal skin. Okay. So these are the structures that are cut during your episiotomy, right? Yes. Now let's talk about perineal tear. Suppose if you are not giving episiotomy, it is going to end up in perineal tear, right? So perineal tear, we have different degrees. Okay. So the first degree perineal tear is going to involve only your vaginal and perineal skin. Okay. And in the second degree, it involves the perineal muscles. Okay. So this is somewhat similar to episiotomy. So your episiotomy is a induced second degree perineal tear, right? And third degree means there is disruption of the anal sphincter also. Okay. So this is further put into 3A, 3B and 3C. 3A means the thickness of external sphincter is less than 50% only involved. Okay. 3B means external anal sphincter is involved more than 50%, and in 3C both your external anal sphincter and internal anal sphincter are involved. Okay. And in your fourth degree tear, which is nothing but your complete perineal tear, there is tear of the rectal mucosa also. Okay. So these are the various degrees of perineal tear. Okay. So what is this drug? This is magnesium sulfate. This is basically used to treat eclampsia as an anticonvulsant, and it is also a drug of choice in eclampsia. Okay. And in severe preeclampsia also it is used. Also it is used in preterm labor as a tocolytic, and finally you can also give this for neuroprotection. Okay, when there is a preterm delivery that is happening less than 32 weeks. Okay, so let us discuss what is the mechanism of action of Maxilf. So mechanism of action, first one, it suppresses sensitivity of the acetylcholine at the motor end plate, and it also reduces the release of acetylcholine also from the nerve end plate. Okay, then it blocks glutaminergic N-methyl D-aspartate receptors, and it is also a competitor of calcium ion. Okay, competitive inhibitor of calcium ion, and besides all these things, it has a direct depressive action on uterine muscle also. Okay. So while giving Maxilf, you have to monitor the toxicity by noting knee jerk, that is always and always patellar reflex must be present, right? And then the respiratory rate should be more than 16 per minute, and the urine output should be more than 100 ml in the last 4 hours. Okay. Suppose if the deep tendon reflex is absent and the respiratory rate comes below 12 per minute and the urine output is less than 80 ml for 12 hours, then what you will do? You will stop Maxilf. Okay. And there are certain contraindications of Maxilf also. Maxilf is not given in myasthenia gravis. Suppose you gave Maxilf and the toxicity has developed. What drug you will prefer to give now? You have to give calcium gluconate as an antidote, which will be 10 ml in 10% IV. Okay, 10 ml of 10% calcium gluconate, that should be given in IV, right? And remember, the therapeutic level of Maxilf is going to be 4 to 7 milliequivalents per liter, and always the pre-treatment level should be less than 2 milliequivalents per liter. Okay. See, you have many regimens for giving Maxelf, but I am telling Zuspi regimen alone. Okay, you will be giving 4 gram Maxelf in 100 ml NS as an IV infusion. That will be given for 20 to 30 minutes. Okay, and following this, it will be given as 1 gram per hour of IV infusion for neuroprotection. Clear? Now, this is your labetalol injection. This is a combined alpha and beta blocker. Onset of action is usually within 1 to 2 minutes, and maximum effect will be reached at 5 minutes, and it will be persisting for up to 4 hours. Okay, it can be given both as orally or as an IV injection also. Okay, it is available as oral as well as IV injection. Okay, IV route is said to be the initial choice in case of severe hypertension, whereas oral route can be given in expectant management. Okay, so the side effect of this drug is it will cause fetal or neonatal bradycardia, and the contraindications of using labetalol or asthma, heart disease, or a congestive heart failure. Okay, right. Now this drug, it is your oxytocin, right? So oxytocin is a drug that is used to stimulate uterine contractions. Okay, stimulate uterine contractions, that is induction of labor or even augmentation of labor when the labor is already progressing. It can also be used in active management of third stage of labor. This is the drug of choice here, as well as to control BPH. Okay, so if you see the T-half of this drug, this is approximately 3 to 4 minutes, and duration of action is for 20 minutes, and it will be quickly metabolized by oxytocinose. Okay, oxytocinose, that's why it is mostly available as a IV injection, but when you give it as IV, the action will be quick and short-lived. Okay, so that's it. So it should be usually stored at a temperature of 2 to 8 degrees Celsius, and the side effects of using this drug will include uterine hyperstimulation. It can go for uterine rupture also with a constriction ring formation. It can go for hypotension, water intoxication, or antidiuresis is also possible with this drug, and it can finally lead to fetal distress or hypoxia or death. So that's why when you put oxytocin for induction or augmentation of labor, there should be rigorous monitoring, right? Now coming to this one, so what do you think this is? This is a dinoprostol vaginal insert. Dinoprostol vaginal insert. Okay, if you see, this is a semi-transparent, thin and flat material that is somewhat rectangular in shape, and it is provided with a long tail also. Okay, so you have a long tail also for easy removal, right? So this is used as a single dose for induction of labor that will be kept high in the posterior fornix. Posterior fornix. Usually this will be removed after 12 hours or with onset of labor. And remember, when you are preferring to use oxytocin while augmentation, this should be removed at least 30 minutes. Okay, so before 30 minutes of starting oxytocin, this should be removed. Clear? Right. Now let us see. So this instrument is nothing but a Kocher's forceps. Okay, where you have a sharp tooth, okay, at the end. Kocher's artery forceps. Okay, so this is basically used for artificial rupturing of membranes and clamping of umbilical cord, and to remove membranes also in either normal delivery or cesarean section, right? So, I showed it here because when you do augmentation with ARM, you will be having to use Colchis forceps, right? Now, what we are seeing? We are seeing iron sucrose injection ampule, right? So, this is mostly given as IV iron injection because it raises HB much faster. Okay, previously IM injection was used and it was iron dextrose or iron sorbitol citrate combination that was given as IM injection, but IM injection was more painful, there was staining as well as it was poorly absorbed as well. Okay, so that's why we have switched on to IV iron now, which is iron sucrose, right? So, what are the indications of IV iron? So, indications of IV iron will include when they are unresponsive to oral iron or there is non-compliance in the patient to take oral iron tablets, there is intolerance to oral iron or there is insufficient time for the oral supplementation to become effective. Okay, then in the patients with gastrointestinal diseases. Okay, then what are the contraindications of IV iron? When there is any active infection or definitely we will not be giving this during the first trimester as well, and when already the patient has an anaphylaxis reaction, okay, previously to IV iron injection. Okay, so how the target iron deficit is calculated? So, the target iron deficit is calculated using the formula body weight into target hemoglobin minus actual hemoglobin, that will be multiplied by 2.4 and to that you will add 500 milligrams. Okay, so here BW is body weight. Okay, the target hemoglobin usually will be taken as 11 and the actual hemoglobin is nothing but the patient's hemoglobin, and 500 milligram is added up to correct the iron stores. Okay, so how we give iron sucrose injection? Okay, so if you take iron sucrose, 1 vial of iron sucrose contains 100 milligram of iron. Okay, so in one setting we can give 200 milligram maximum. So we will take 2 vials, okay, of iron sucrose in one setting, and this will be diluted in 100 ml in NS, and it will be given at a rate not more than 20 milligram per minute. Okay, and it will be given in 3 doses on alternate days. Okay, so it will be given on first day, third day and fifth day. So maximum dose per week is 600 milligram per week, right? Yes. Now we can also give another drug, that is ferric carboxymaltose, which can be given at a dose of 1000 milligram in a single dose itself. Okay, suppose if second dose of FCM is required, means you can repeat it after 1 week. Okay, okay. Now this table is nothing but your modified Bishop score. Okay, so this is a modified Bishop score. Now this table is very important in determining the successfulness of the induction of labor. Okay, so you have 5 components, and among the 5, 4 components will be speaking upon cervix only. Okay, what is the dilatation of the cervix, what is the consistency of the cervix, what is the length of the cervix, what is the position of the cervix, and finally we will be speaking about the station of the fetal head in respect to the visual spines, right? So the score is given from 0 to 3, And dilatation of the cervix, if it is less than 1, and it will be taking score 0. When it is between 1 to 2, it will be taking score 1. When it is between 2 to 4, it is taking score 2. And when it is more than 4, it is taking score 3. Okay. And consistency of the cervix is FMS. Okay. So that is firm, medium and soft. Then for 3, you don't have anything. Okay. Length of the cervix, you will start from 4. Okay. And you will start reducing, because as the effacement is happening, then the more favorable the prognosis is, right? So it is 4 first, then it is gradually reducing 2 to 4, 1 to 2 and less than 1, like that. And position of the cervix is again PMA. Okay, so it is posterior, mid and anterior. Anterior cervix means you have more favorable prognosis. Okay, then station, you have to start from -3. So -3, -2, -1, 0 and +1 and +2 will take more favorable prognosis. Clear? Now coming to Apgar score. So this score is also very important. Okay, so you have appearance, pulse, grimace, activity and respiration, and the scores are given from score 0, score 1 and score 2. Okay, score 0 when the baby is pale or blue and there is no pulse, there is no response to stimulation, and when there is no movement or no breathing, nothing is there, you will give score 0. Okay, and the baby will be pale or blue. And score 1 is given when the extremities are blue. Okay, so and the heartbeat is less than 100 beats per minute. There is a grimace or weak eye, the arms and legs are flexed, and there is slow irregular respiration. Okay, score 2 is given when full body is pink and the heartbeat is more than 100 beats per minute, and the baby cries and pulls away, and there is active movement of the baby as well as it has a strong cry. Clear? So Apgar score is also important. Now this is your biophysical profile, which is used for determining the fetal well-being. Okay, but I don't want you to remember everything. You have to remember only the components of biophysical profile that can be remembered by the term Batman. Okay, so B for fetal breathing, A for amniotic fluid, T for fetal tone, M for fetal movement, and finally N for NST. Okay, among these 2 components are taken and they are calculated as modified biophysical profile. So that is AFI, that is amniotic fluid, and your NST. Okay, so these 2 things will be taken as modified biophysical profile. Is that clear? Right. Now, okay, so this table is very important. This is a modified Robson's criteria. Modified Robson's criteria, where the pregnant ladies are classified into so many groups according to their history and the number of fetuses and so on, right? Now this table is very important for you. Here we will be dividing the pregnant ladies into so many groups. Okay, so this table is a modified Robson's classification. Okay, so we have 10 groups. In group 1, you have nulliparous female with single cephalic presentation baby that is more than 37 weeks of gestational age and she is in spontaneous labor. Okay, and in 2A, you have a nulliparous female with single cephalic presentation baby that is more than 37 weeks, that is term only, and it is induced labor. Okay, in 2B, again it is nulliparous single cephalic baby more than 37 weeks, but she had cesarean section before labor. Okay, she was a previous LSES, right? And third group is multiparous women, excluding previous cesarean sections. We are taking her as a multiparous woman. She has a single cephalic presentation that is more than 37 weeks and she is in spontaneous labor. Again 4A, multiparous female, that is excluding previous cesarean section. She is having a single cephalic presentation that is more than 37 weeks and it is induced labor. Okay. 4B is multiparous woman with single cephalic presentation. There was cesarean section before labor. Okay. So first is spontaneous labor, induced labor, then cesarean before labor. This is repeated in 1, 2A, 2B, 3, 4A and 4B. Okay, you have to divide this. First is nulliparous woman we are speaking, and all of these are above 37 weeks only. Clear? Right. And the next one, fifth one, previous cesarean section, single cephalic, that is more than 37 weeks. So previous cesarean section means 5 cesarean sections. Okay, keep it in mind like that. Then breech means 6. Okay, so if you take breech, if the buttocks comes down, it will be like this, right? So it is 6 breech. Then 7, all multiparous breeches. 6 and 7 are breeches. 6 is nulliparous breech and 7 is multiparous breech. And 8, all multiple pregnancies. Okay, 8 means many. Okay, you have so many. Okay, so that is including previous cesareans. So, in the 9th group, we have all abnormal lies, including previous cesarean sections, and 10th group is preterm, okay, including previous cesarean sections, okay, that is less than 36 weeks. Is that clear? Right. Now, what is this? So, this test is basically called as non-stress test, okay. This is called as non-stress test when it is done routinely, okay. Suppose the patient is coming for a routine checkup and you want to check the well-being of the fetus by performing this test, it will be called as NSE. Suppose the same test when you give the patient when she is in labor, then it will be called as CTG, because during this time we will be monitoring the uterine contractions also using the turbodynamometer. Is that clear? Right. Now, when you see the strip, okay, you are able to see two panels. Okay, the first panel will be talking mostly about the baby, okay, including the how is the heart rate and how was the acceleration, whether there is any deceleration like this. And there is a lower panel where it will be talking about the uterine contractions. And most of the times when the female comes for routine checkup, we are not worried about the lower panel because she will be painless, right? And the lower panel is very important when you have induced the woman or already she is in labor, okay, right? And the speed of NST paper is 1 centimeter per minute, right? Now, let us see the first chart where we are going to see about the fetal heart rate, okay. So, normally the fetal heart rate is taken between 110 to 160 beats per minute, right. Suppose if it is less than 110, it is going to be baseline bradycardia, and if it is more than 160, it is going to be baseline tachycardia. That means when baseline bradycardia is there, it means your parasympathetic activity is going to be high, whereas when it is more than 160, your sympathetic activity is going to be high, okay. So, this is your fetal heart rate. So, here roughly if you see, the baseline is under 120, okay. So, it is 120 beats per minute, which is normal, right. Now, coming to the next one, here we are going to check about the variability. The variability normally it is between 5 to 25, okay, 5 to 25 beats per minute, right. So, that means that variability, if it is good, means then it means that there is an intact neuronal pathway, okay, there is intact neural pathway, okay, that will include your cerebral cortex, midbrain, vagus nerve, etc., right. So, 1 minute portion of CTG has to be checked here, and if it is more than, so how many boxes are moving, you have to see, okay. So, if it is increased, then there is hypoxia, acute hypoxia, right. And when it is decreased, that means fetal sleep is possible, and when it is less than 28 weeks, definitely the variability will be very less because there will be immature ANS system. Immature ANS system, right? Okay. So, this is a reduced variability. You are able to see the difference, right? So, here you are able to see this is going for 1, 2 boxes, okay? Whereas here it is not even crossing 1 box, okay? So, this is a picture of reduced variability, right? Now, coming to this pattern. So, this is your favorite pattern, that is a sinusoidal pattern, which is a smooth undulating sine wave pattern, okay. So, basically here the variability will be somewhere between 2 to 5 beats per minute, and the causes of the sinusoidal pattern are fetal anemia, okay, especially in your RH negative, RH incompatibility, then when you have TTTS, or if there is severe hypoxia also, you will be able to see this condition, okay. Severe hypoxia means there will be umbilical cord compression, okay. So, in that case also we will be able to see this sinusoidal pattern. Is that clear? Right. Now, coming to the next one. So, here we are seeing the accelerations. Accelerations means from the baseline a peak of waves are seen, okay. So, this peak of waves will be going for up to 5 to 15 beats per minute, okay. So, that is nothing but the increase in the fetal heart rate only, that will be going for 5 to 15 beats per minute, and it will be lasting for 15 seconds. Why these accelerations are happening? Because in response to fetal movement or uterine contraction, you see this accelerations, okay. Suppose accelerations are not seen. Accelerations are absent in a NST means there can be chances that the fetus will be sleeping and it can be waked up by performing acoustic stimulation, and then you can repeat the NST again. Okay, then repeat the NST. Okay, and remember, if acceleration is plus, then it means the fetal well-being is good. Okay, suppose if it is absent, it does not mean the fetus is not good. Okay, so the vice versa is not true in this case. Clear? Right. Now let us speak about decelerations. Decelerations will take the same definition. Transient fall in fetal heart rate up to 15 beats per minute, that will be lasting for 15 seconds. Okay, but we have three types of decelerations. First one is your early deceleration. Okay, so when we talk about early deceleration, first let me show this one, then we'll go there. Okay, now in this picture, if you see, these are the fetal heart rate, and this is going to be your uterine contractions. Okay, so in early deceleration, what is going to happen is, these are going to be like a mirror image of each other. Okay, so exactly in the same position. Okay, so this is type 1 deceleration. You will be able to see a V dip. Okay, you will be able to see a V dip, and early deceleration is mostly because of head compression. Clear? And next one is late deceleration. See, it comes late. Okay, the deceleration comes after the uterine contraction. That is why it is called as late deceleration. Okay, so this is a type 2 deceleration. You will be seeing a U dip. Okay, so this is a U dip and it occurs due to uteroplacental insufficiency. Clear? And finally, you have variable decelerations. In variable decelerations, it is inconsistent in the shape, form as well as timing in relationship to the uterine contractions. Okay, whenever you are not able to make out either it as a early deceleration or a variable or a late deceleration, then it will be called as a variable deceleration. Is that clear? Right. So, this is due to mostly your umbilical cord compression. Clear? Right. Now, let us see these papers so that we will be able to understand. Okay. So, here we have a V dip that is coinciding exactly with the uterine contraction. So, this is an early deceleration. Early deceleration occurs due to head compression, right? And coming to the next one, variable deceleration. So, variable deceleration means, see, uterine contractions are here, okay, but here you have one deceleration and here you have one deceleration, but here you doesn't have anything and it is occurring randomly, haphazardly, okay. So, that means it is a variable deceleration, and variable deceleration occurs due to cord compression, right? Now, coming to the next one, that is late deceleration, okay. So, after every uterine contraction, you will be able to see one deceleration that is in the shape of U, okay. Just after the uterine contraction, you will be seeing this, okay. So, that is your late deceleration. It is due to your uteroplacental insufficiency. Is that clear? Right. Now, let us see this one. I am going to talk about the portogram, but you have to understand that two types of portogram are important, okay. I am not going to discuss from the beginning what portograms are used and all. You have to know that two portograms are now here. One is your WHO modified portograph. Okay, so this is your WHO modified portograph, and the other one is your next generation portogram. Okay, so next generation portogram. Okay, so this is the recent one. Okay, this is also coming under the WHO labor care guide. Okay, so this is the preferred one also. Okay, now let us see what are the difference between these two. How to identify this? You will be able to see alert line and action line in case of modified photograph, whereas in next generation photogram you don't have anything. And another simple way to identify next generation photogram is by seeing your active first stage and second stage. Both the stages will be given separate columns. Clear? Now let us see what are the difference between these two, and then we will see the next generation photogram in detail, right? So first one, here in the modified photogram, the active phase is defined as starting from 4 cm of cervical dilatation, okay, whereas in labor care guide, cervical dilatation starts from 5 cm, right? And then the rate of dilatation is fixed. It is 1 cm per hour. Okay, you have alert line and action line for that. Whereas here there is evidence based time limits at each centimeter of cervical dilatation. Okay, so we are not fixing it. Okay, it differs from female to female. That one we have to understand, right? And here there is no second stage section, whereas here you have a separate section for your second stage, right? And here there is no monitoring of supportive care or any interventions made like that. But here we monitor supportive care, and whatever interventions we are making at each point will be marking it. Clear? So these are the major differences. I don't want to drag this. So let us discuss in detail about the labor care guide. Okay. So in labor care guide you have 7 sections. Okay. So that is important. Section 1 is going to speak about the identification of the mother. Basically about the identification of the mother. So we will be talking about her name, variety and labor onset. Okay. Whether it was spontaneous or induced. Then what is the date of active labor diagnosis. Also, if she had a ruptured membranes at presentation itself, if she had ruptured membranes, then it will be mentioned accordingly, and if she doesn't know that history, it will be mentioned as U, right? It is unknown, right? And the next one is, if any associated risk factors is present in the mother, that will also be mentioned, right? And the next one is section 2. So here basically we are going to speak about the supportive care for the women. Okay, we are going to speak about the supportive care for the women. Okay, so we will speak about the companionship, pain relief, oral fluids, then her posture, what posture she would like to maintain, like that. Okay, then coming to section 3. Basically, we talk about the baby here, okay, about the fetal heart rate, if any decelerations are present, and decelerations are given separate identities like E, V and L, that is early deceleration, variable deceleration and late deceleration, it has to be mentioned separately. And then you have to speak about the amniotic fluid, fetal position, okay, and if there is any caput or okay. And one more thing is, fetal heart rate should be monitored in the first stage for every 30 minutes, okay, every 30 minutes, and in the second stage every 5 minutes. Is that clear? Right. Now coming to section 4. In section 4, basically we will be talking everything about the mother, okay, like what is her pulse, what is her BP. BP will be mentioned separately, like what is her systolic BP, what is her diastolic BP. They are given cutoffs also. In the chart itself, you will have the cutoffs also. Cutoffs are less than 80 and more than or equal to 140, and diastolic means if it is more than or equal to 90, you have to mention it, right? And the next one, definitely we will be talking about the temperature as well as urine. In the urine, we will be talking about proteinuria and ketonuria separately. Okay, so this is something different. Okay. Next is section 5. We will be talking about the labor characteristics here. So we will talk about how many contractions she has, okay, in 10 minutes. If it is less than or equal to 2, then it is insufficient, and when it is more than 5, it is going to be a obstructed labor. Clear? And the next one is the duration of contractions. If it is less than 20 seconds, then it is said to be inadequate. Whereas, if it is more than 60 seconds, then it is in obstructed labor. Okay. Sometimes It can be continuous contraction also. That time also it is going to be obstructed labor. Okay, one important thing you have to know is we have to monitor contractions and the durations. Okay, every 30 minutes in your first stage and every 15 minutes in your second stage. Clear? Right. We'll also be monitoring the cervical dilatation, which is mentioned as X. Okay, and if the mother starts pushing, it will be mentioned as P separately. Okay, it is pushing begins. And regarding the descent of the fetal head, it will be mentioned 0. Clear? Right. Now coming to section 6. Here we are going to talk about the assessment and plan. Now this is also new in this labor care guide because we don't have so much significance in the modified protogram, right? So here we'll be talking about assessment. Assessment means the overall assessment what you made, that has to be recorded separately. And plan means, for example, you can mention it as continue routine monitoring, okay, or offer ARM or augment with oxytocin, like that. Whatever plan you are making, that has to be recorded separately, right? So women should be involved in the discussions. That is very important. Okay, women should be involved in the discussions, and every parameter is normal means reassessment will be done after 4 hours. Okay, for every parameter when it is normal, reassessment will be done after 4 hours, right? So this is all about your labor care guide. Okay, so with this we are finishing this image based discussion in your obstetrics and gynecology. I hope you are preparing for your exams very well and you will also come up with flying colors. So until then, take care, happy learning, keep going, and bye bye.